Good morning, everyone. Thank you, Marguerite. Good morning, everyone. I'm Councilwoman Felicia Porter, representing the 10th District and Chair of the Public Health and Environment Committee. Just a reminder, please turn off or mute all cell phones, as we don't want to have the distraction during this very robust hearing today. Also joining us, we have committee members, Councilman Ryan Dorsey from the 3rd District. We also have Councilman Mark Parker from the 1st District. And we also have several representatives from the Mayor's Office and City Council President's Office, with committee staff person Marguerite Curran to staff. Today, we are discussing the city's response to the opioid crisis. This is an opportunity to provide a platform to city agencies, healthcare providers, community advocates to discuss ongoing challenges, identifying service gaps, and explore policy solutions to enhance Baltimore's collective response to the opioid addiction and overdose prevention crisis that we see in our city. I'll take a moment of privilege here. I'm so grateful to see so many of you all come out today to discuss this matter. I know this is a long time coming for the city of Baltimore. I understand that the generational issues of addiction and, quite frankly, just quality of life for all persons within our city are at top of mind for many in this room. My goal for these 4 legislative oversight hearings is to stop talking. This is an opportunity for us to have real impactful work that can change generations within the city of Baltimore. You all know me well enough to understand that this is an opportunity and my life's work. Given that I am in public health, I am a resident of Baltimore, I'm born and raised in Baltimore, and I've been in Baltimore all of my life. And I have seen the power of when we have collective action towards an issue, but also when we have political will. As the council holds these hearings, particularly the next 4 in July, you will hear from members various questions, various ideas of sustainability, but more importantly, to figure out how we got here, and also to see how we are going to get out of this, to see how we're going to live in a space where everyone, regardless of your status, in recovery, regardless of your neighborhood, you will have an opportunity to engage in this process. And so just want to set that grounding here. I formally want to welcome our new health commissioner back into the chambers. Just want to formally recognize her, but also I want to formally recognize and welcome back Dr. D. Just want to take that moment of privilege for Dr. D, all that you have done for the health department during COVID and into now. So we are so excited for you. And last but certainly not least, I also want to take a moment of privilege to give a swan song to Allie. I call her Allie. For all the work that you have done with the Behavioral Health Collaborative. It is a joy to see you and to have witnessed you blossom in this role over the past 10 years. I know you've been in city government for a very long time now, and you've seen time and time again the ins and outs of city government, but you have also been a witness and an integral part in making government work for the city of Baltimore. So I just want to give you your flowers formally and publicly for the record. All right, we are going to start with public testimony, and that's a little bit outside of how other committees do it. I want to make sure that committee members and the public can hear from subject matter experts on what they want to see with regard to harm reduction, the opioid addiction and the opioid crisis here in the city of Baltimore. So we're gonna start public testimony. I will remind you all that you will have 2 minutes. There will be a timer on the screen. Because we have such a robust presentation from our agencies, please make sure that your public testimony is at 2 minutes or close to 2 minutes. I would hate to interrupt you, but I will. So we will start with the first person in public testimony. We have, Darcy Kerwin Garber from Baltimore Harm Reduction Coalition. Perfect, thank you, ma'am. If you press the button on there, it will turn red and then
That will
everyone
help
can
as
hear
well.
you. Wonderful.
Thank you so much. Appreciate the opportunity to speak today and for public comment. I'm Darcy Kerwin-Garber. I'm the policy manager at Baltimore Harm Reduction Coalition. We work towards the health, dignity, and safety of people targeted by racist war on drugs and anti-sex worker policies. So we do that through community outreach, community trainings, as well as advocacy, and we are very proud to be one of the 8 syringe service programs in Baltimore City. So as part of that, I'm sure from the other testimonies that we've provided, especially by City Health Department and other agencies, you'll hear how amazing syringe service programs are, how important they are. I do want to focus on how the criminalization of paraphernalia limits their effectiveness. So we know this is a state law that syringes are considered a controlled paraphernalia, and so it can be, people are at risk of anywhere from a misdemeanor to 4 years incarceration and $25,000 fine just for paraphernalia, regardless of other drugs. And so we know that this often stops participants from engaging with our services. They're afraid of being engaged by police in ways they don't want to be, or of having their tools and their sterile equipment confiscated, which can kind of upend someone's entire day as they're trying to then be safe again. So we know that it impacts people from engaging in our services. We've had quotes from participants saying that they've seen people pick up syringes from the ground that are used and using those instead because they are afraid to engage with sterile harm reduction products. So that is absolutely an issue. We know that the sterile syringes reduce the transference of HIV and hepatitis C, that they can reduce soft tissue wounds. All of this engagement helps people connect to services by engaging in syringe service programs. So we have this law that we know prevents people from engaging in something that we know critically important to overdose prevention in the city. We know that it actually encourages and incentivizes the sharing of syringes so that people aren't gonna carry their own. It's more likely to share with others. We know that, is that the end? There we go. Okay, the goal is we recognize this as a state law, but that also your support during legislative session to try to have amendments to this, as well as what does this look like in practice at the city level. So I know previously there's been a de facto decriminalization of paraphernalia, like prosecutorial discretion, or that it's meetings with BPD of we don't confiscate paraphernalia because we know that it actually puts people more at risk. That is a matter of public safety for everyone in Baltimore.
Thank you so much for your
Appreciate it.
testimony.
Thank you.
We have Ricardo Burks from Healthcare for the Homeless, Baltimore.
Good morning. Good morning. My name is Ricardo Burks. I'm a case manager with supportive housing at Healthcare for the Homeless, and I thank you for the opportunity to come this morning to speak to you. We stand with our partners in strong support of harm reduction policies, including the overdose prevention centers, which are essential for addressing the opioid crisis in Baltimore. But however, I want to focus my testimony this morning on one critical aspect of harm reduction, and that is affordable housing and available shelter space in Baltimore. When individuals are battling opioid addiction, the lack of affordable housing and bed space contributes to the ongoing public crisis, particularly for those that are struggling with that addiction. When individuals are forced to sleep on the streets or overcrowded shelters, it becomes almost impossible for them to recover. The constant stress of just survival, of knowing what's gonna happen from day to day, where they're gonna sleep and how to stay warm, it prevents them from actually participating in recovery. Keeping people in a state of crisis, they're unable to recover from their addiction. Without stable housing, access to treatment becomes inconsistent. Medications for opioid addiction, such as methadone and Suboxone, it often requires daily visits to treatment centers. And these treatment centers, sometimes there are hindrances of getting there, transportation barriers and stigma. Particular individuals that are sleeping on the streets endure colds and infections, and they have problems with other medical issues. The opioid addiction crisis is also, it really is a housing crisis. It represents a failure to meet a basic human need, and that is housing. I want to just shift and say this in closing. If we want to reduce the opioid-related deaths, we must treat housing as a healthcare problem. We need more low-barrier shelter beds. We need more affordable housing, and we need to meet people where they are. Investing in housing, supportive housing, is not only compassionate, it is a smart policy. It serves as the foundation of recovery, stability, and a fruitful life. Let's make Baltimore a leader in evidence-based harm reduction. Thank you for your time.
Yes, of course. Thank you so much, sir. All right. Yes, I see it. Thank you. We also have Angela Cruz Williams. Are you online?
She's trying to get a parking place yet.
Oh, of course.
Okay, she'll be here in a moment.
Okay, no worries. Thank you. Are you from Mall Park? Yes. Thank you. All right, great. Yes. All right, and I also want to recognize Councilman John Bullock as well from the 9th District, member of the committee. Thank you, Madam Chair. All right, we have Catalina Bird.
This is the wrong one. I'm supposed to push this red button. Oh, good morning. Well, they had clocks up there anyway. Good morning. Hi, Councilman. I came in part to support Ally, so it's weird that I'm going first, but, and thankfulness for all the work that she's done. And just to ask that in her absence, it continues, that the collaboration continues and the understanding that public safety, harm reduction, public health, and the opioid crisis are all very much intertwined. I live off of Pennsylvania Avenue. I'm in Councilman Bullock's district. And so what we see on Pennsylvania and Lawrence every day in front of the Avenue Market is just evidence of the fact that we're missing the mark somewhere in how it is that we are getting to individuals. And when I speak to them, one thing that they say is they feel like they're brought into programs for the use of being able to bill Medicaid, and they don't feel as though they are actually getting the sort of resources that they need. It's become a cash cow for certain people in the industry, but it's not resulting in them getting what they need to be able to live healthy, sober lives and continue to thrive going forward. I would also urge us to understand that while we've made great things, we know what the person in the White House is doing right now, and with cuts to Medicaid, when those people stop being beneficial to the people that came into the work to profit from it, do we have a safety net, or even are we even thinking ahead of a safety net for what's gonna happen when many of those organizations have to close their doors? And just thank you all for listening. Hi, Ryan. How are you? So great to see you this morning. Just don't allow them to politicize this. I know there's a lot going on in the country, a lot going on in the state. Next year, sessions that happen during legislative re-election years very rarely get a lot of things done. But I ask that you all as a body force the Baltimore City delegation to not play politics and know that this is a critical time for all of us. Thank you.
Perfect. Thank you so much, Catalina. We also have Vin McCormick.
Thank you, Chair Porter. My name is Vin McCormick. I am the Executive Director of the New Life Recovery Center. 2 minutes, huh? Okay. I know people like data, so let me give a little bit of data from the CDC. Baltimore City, despite comprising about 9% of Maryland's population, accounted for over 38% of statewide overdose deaths, which says a lot. I was listening to Ms. Catalina, and she was talking about where she is in terms of Pennsylvania and Lawrence. I'm very familiar with that area. I'm very familiar with opioid, the epidemic. We have right now probably 4 out of 7 clients who come to our facility are opioid users. And of those 4 clients are MAT clients, MAT meaning methadone, or Suboxone. That's a whole nother conversation now. I only got a minute 8 left. So what I've learned, Chair and fellow council members, appreciate you coming, is that programs such as myself can't wait in our wonderful offices that we set up for the clients to come to us. We have to take our program to the street. So what we try and do at New Life is we try and take our resources out. We were on Penn North, we were on Penn and Lawrence, but that was in response to the city situation with the murder, but we were out there and they were out there a little bit past that. So we try and go out at least 4 times a month as an agency. What I would really like to see, this is on my wish list, is for all the agencies in Baltimore City that do what I do, is to collaborate without a mandate from the city or without Chair Porter, who's wonderful at this, saying, hey y'all, let's all get together and let's go out on a regular basis to the hardest areas of Baltimore. That's what I wish would happen. Maybe that'll happen in my lifetime, but we have a difficult climate, as you know, Chair, in behavioral health. You know, it doesn't work like that easily. So we're here. We're just up the street. We're blessed to have a new facility for returning citizens. We've got 4 of 7. We've got in-house staff to attend to MAT. We've got a program around the clock. So we try, and I appreciate Mr. Ricardo. Housing is an issue. It is an issue. So we're trying to address that with a new facility where Kathy Hughes' situation, business was. And I'm gonna be obedient to time, Chair, but I appreciate what you're doing here. Thank you all very much.
Thank you so much, Mr. McCormick. All right. Did Angela Cruz come in yet? No. All right, perfect. Next, we're gonna go to Candy Kerr. My apologies.
If it gets me up here.
My apologies.
I'm wasting time. Here. My name's Candy Kerr. I work with Baltimore Harm Reduction Coalition. Thank you all for holding this. Thank you, Felicia. You've been supportive of us in a few different ways. Yeah, I was joking on the way up here in the elevator, and before I got in the elevator, that it's like a family reunion whenever I come to these things, because I just see all the people that I've been doing this work with for the last 7 and so years. And I feel like we're gonna say the same things that we've been saying for the last 7 years. And there's a lot of different reasons for that, you know what I mean? But I think I'm just gonna reemphasize what I always say. One of those things is, somebody that I wish could be here to do this instead of me is named William Miller Sr. He was a person that was in the forefront of harm reduction in Baltimore City. We used to call him the grandfather of harm reduction. He was one of the people that helped me get into harm reduction and show me what it looks like to meet people where they're at and not leave them there. One of the things that he was really passionate about was having overdose prevention centers open in the city of Baltimore and the state of Maryland in general. He was consistently fighting for that. If one of those would have been open in the state of Baltimore, we might not have lost him to overdose a few years ago. And so I come here to stand on that. I like to bring him into the room because I like to remind people that this is a thing that we're going to continue to deal with, and it's about people. Overdose prevention centers help people. There's a lot of stuff in New York. There's a lot of stuff that I can send all of you via email, but overdose prevention centers do a few things. One of them, it helps stabilize people enough to be able to get help with housing. Housing is a public health issue. It helps people find different resources that they need, and it also brings them out or brings them in from the heat, from the cold, and allows them a little bit of dignity, a little bit of self-respect. I mean, they already can have self-respect, but it just helps bolster that. And so that's the thing that we need, overdose prevention centers. Thanks.
Thank you. And now that Angie has joined, I'll go back to Angela Williams Cruz.
Good morning, Chair Porter. How are you?
I'm good, how are you?
Nice to see you.
Yes, ma'am.
I apologize. I just wanted to read out loud the testimony that I turned in. My name's Angela Cruz Williams. I'm the president of the Morrill Park Community Association. I stand with you today to represent an overwhelming voice in my neighborhood, Morrow Park, which has clearly expressed its strong opposition to the presence of mobile clinics that are distributing needles, Suboxone, and drug paraphernalia in the community. While we recognize the intentions of the people working for those mobile units is to help, the majority of the residents believe that this approach is enabling a destructive behavior rather than providing solutions. Sorry. The impact on our neighborhood has been very significant. Needle litter has become a huge concern, with many residents finding dirty needles on our streets. Just a few weeks ago, a local business had to clean up needles with blood still inside of them before opening its doors. A few days ago on the 4th of July, a 7-year-old came within probably 2 inches of stepping on a dirty needle in his own backyard. Morrow Park Community Association also has concerns about the distribution of Suboxones without proper oversight. There are instances where I've actually spoke to individuals that receive both Suboxones and methadone from the clinic up the street. So it's about a block in between each other. I'm sorry. We've heard firsthand about them selling those medications to fund their addictions. The lack of accountability undermines the purpose of these programs. There's also something that's been passed out in our neighborhood, and they call them the Getting High kits. These kits raise a lot of questions. We understand the need for tools like testing strips and we understand the tools like testing kits and things that are needed to make sure you don't overdose. But in a lot of cases, we're told that there's needles provided and things that actually help people do their drug, which we feel like that's counterproductive. We urge Baltimore City to seek a real solution, such as enforcing petty crimes, laws against petty crimes, I apologize, involving the addicted individual's family or a support system, or when sending them to rehabilitation centers, send them outside of Baltimore City limits to help gain control of their lives. I actually just spoke to somebody recently. The whole neighborhood thought that he had passed away, and he popped up out of nowhere on the 4th of July to visit family, and he said that he actually ended up outside of Baltimore City to the Hope House, and he's all about the Christian life now. So he did not pass away. He's off of drugs, and he's doing great now.
Thank you.
And it was wonderful to see him alive because the whole neighborhood thought he had passed away. All of the Morrow Park community members deserve to feel safe and respected. Most of the community has never used drugs or are not on drugs. Yet we're still deeply affected by the behaviors of those that do use drugs. It's time to prioritize the needs of all residents and not just the ones struggling with addiction. Again, we do understand, we definitely are in full support of getting help for those that want to have help. But if they're actively telling you they're not ready, then there needs to be a better solution because it messes with the community members that are not doing the drugs.
Thank you so much, Angie. Thank you.
Thank you very much.
Of course.
And it was great seeing you.
Yes,
Thank
ma'am. Great seeing you as well. Next, we'll hear from Bakari Aliba. And my apologies if I pronounced your name wrong. Yes.
Just talk?
Yes, sir, you have 2 minutes.
All right, good morning. I don't have a lot to say, but what I do want to emphasize is that people need more access to harm reduction services. We do a lot of outreach in East Baltimore. We just started expanding into West Baltimore doing outreach. There's a lot of issues in a lot of communities with public use. There's a lot of issues with syringe litter and things like that. We need more drop-in centers, right? We need more spaces in the city where people can go, they can feel safe, they can take a shower, they can get something to eat, they can get clothes, they can be connected to case management for various services such as simple things as like getting your ID, your birth certificate, your social security card. The issue that I've noticed that we have in the city is that there's not a lot of low barrier services. And a lot of the services are so high barrier, the people that really need them, they are unable to access them. So I must emphasize that we need to work together and collaborate to figure out how can we meet people where they're really at. People want the services. People want to get off the streets. We all know housing is a big issue in Baltimore City. People want to get off the streets. People want the services, but the access to them are so high barrier, it's hard for them to get these services. So we really need to collaborate and figure out ways how CBOs, city agencies can come together and meet each other where they're at so that we can lower the barriers to people getting services. And I think that's gonna make a big difference. And it starts with drop-in centers. We need more drop-in centers throughout the city. We need more spaces where people can get off the street and have the services right there in front of them. When a person is ready to go into treatment, if we cannot get a person into treatment immediately, 9 times out of 10, we'll lose them. If I'm ready, I'm ready. Not today, not tomorrow. We can't tell a person, come back tomorrow morning and we'll help you navigate getting into recovery because anything can happen in a 24, 12-hour period. So we need more spaces where people can come in and get services immediately, like right away. We can't put people on pause because addiction is not on pause. Homelessness is not on pause, right? Unemployment is not on pause. So we need to be able to create spaces where people can access low barrier everyday services on a consistent basis. And I just feel like, if we could add more drop-in centers where we could do case management, where they can get easier access to healthcare and testing and things of that nature, I think it would make a big difference in the city.
Thank you so much. Next, I want to call Charlene Bees. It's all right.
Wait for any replacement.
No, you're fine. You're good.
All righty, good morning. I don't have a title or anything like that. I'm just a old, lifelong member of Morrow Park. And I don't have a letter, I just have a list of my concerns, the way I see things. Number one, the infestation of drug addicts it's drastically increasing. It's like an infestation. Number two, the attempts to help them seem to be enabling them, just masking the problem versus actually providing the help they so desperately need. Haven't seen the surrounding neighborhoods as heavily populated with the addicts on the main corridor as us. So many unwanted people who sell drugs, they don't even live in our neighborhoods or neighborhood, and the cars coming into the neighborhood to support these dealers. The filth from the addicts' lifestyle, the trash they leave behind. The addicts need some kind of accountability for their actions, some consequences rather than always rewarding their behavior. frequent use of our fire department for overdosing or under the influencing called heroin hunch, can't shop the local businesses without stepping around them, over them, weaving in and out, and excusing myself or being approached. I can't have packages delivered because the addicts have become porch pirates, and I'm taking a big financial loss. I have to turn my outside water off to prevent them from showering, making my water bill higher than it already is. I'm concerned for our school-age children who wait for the bus to go home, having to walk the boulevard to get to school, and how many of them too have to get around and internalize this as a way of life. My neighborhood's not as appealing to new homeowners. Instead, we're getting people who are doctoring up houses to become Section 8 housing. And nothing wrong with Section 8, but the kind of Section 8 that we seem to be getting seem to bring many of their unwanted behaviors. Oops. Can I just summarize?
Yep.
Okay. Many of us want our life back, to come to a place we call home, and to cohesively live together. What would be a definition of a neighborhood or a community? I think it's very selfish of the city's part, neglecting the rest of us or the rest of the community on their behalf. As far as favoring the vans and the needles and the distributing of drugs like Suboxone and methadone, why can't you round them up, put them on buses, and relocate them to your neighborhoods so you can get a better picture of what it's like to live in these deplorable conditions?
Thank you so much.
Thank you.
Thank you. Next, we have Marguerite Lennox.
My apologies.
No, you're fine. We'll start the time when you start talking.
Okay.
No worries, take your time. And I'll take a moment while you're finding your testimony. All, if you have not signed up for testimony and you still want to testify, please form a line in the middle, please. Thank you.
Good morning. My name is Marguerite Leno, and I am the public defender for Baltimore City in the Baltimore City District. And under the leadership of Public Defender Dartigue, we just wanted to take a moment and put some emphasis on the need for peer interventions and pretrial interventions. We know the crisis was fueled by Big Pharma, but the impacts have devastated communities already facing deep inequities. Now, with the settlement funds, there's an opportunity and an obligation to reconcile not just the overdose crisis itself, but the historic over-policing and criminalization of substance use disorder. Policing, prosecution, and punishment work against the vision to redress harm, reduce fatalities, and invest in communities in a restorative, community-based, data-driven way. The data is clear. Peer-led interventions work. When people are supported by trained peer specialists, they are more likely to find stability and less likely to be reincarcerated. Incarceration does not improve outcomes, it's costly, and it breaks the trust of the community. The focus needs to be shifted. Make peer support an alternative to arrest, not just at reentry, but an alternative at the point of initial police interaction. Expand diversion programs that are justice supported, evidence-based, and rooted in lived experience. Apply the data equitably. If we know that older Black men are dying at disproportionate rates, we can't design programs that exclude people because of their criminal history. Jail is not recovery. It may feel like action, but it doesn't drive meaningful change. Many of our clients are held pretrial, often to sit at least for 45 days. That's a long time lost if there's no real treatment and connection to care during that window. The Public Defender's Office stands ready to partner in reimagining how this looks and what this looks like to build true community-based pathways, expand peer-led responses, and push the system to do more than maintain the status quo. And thank you for your commitment at this moment, and I hope that it's one that we take the time to make it count.
Thank you so much. And last but certainly, we have one more person.
Okay.
Last but certainly not least, Ms. Jody Jackson.
Good morning. My name is Jody Jackson. I'm from Morrow Park. I grew up there, moved back there with my kids, raised them. They graduated school, went to college. The neighborhood, it was a blue-collar neighborhood. Everybody worked. Everybody kept their yards clean. Nobody worried about stealing stuff from porches, packages, furniture, Christmas decorations. Now, I even had a basil plant stolen from the front of my yard. I guess they thought it was something else, I don't know. I'm afraid for the children living in our area now. They think it's normal to see drugs, people doing drugs, people half-dressed, standing on corners. This is not a way I want my grandchildren to believe the neighborhood is or what life is like. I'm more concerned for all the kids in Morrow Park. You see them walking on the boulevard. It used to be stores. I just don't know how to describe it. It was a completely different, 10 years ago it was different. It is so many drugs around there now. It's nothing to go out a house and find drugs on the street. I mean, I used to be able to go out of my house, go to the alley barefooted, okay? I wouldn't dare do that now. I have pets, I have grandchildren, there's children that live next door to me. Seeing the people walk up the street, well, the druggies, bending
Ma'am.
halfway over, falling
Yes.
in the street.
And so thank you so much for providing your testimony. I'm going to give you about 10 seconds back, but I just want to clarify, if we can say addicts or persons experiencing drugs.
Okay, not druggies,
Yes,
okay.
thank you so
fine.
much. I
Addicts.
appreciate you. Thank you.
Addicts.
Thank you.
I'm sorry.
It's okay.
I apologize.
No, it's okay.
For the correct term. The addicts walking up the street, bending over.
Mm-hmm.
They can't stand up straight. They're on the corner sitting down. What do you tell your children?
Yes, ma'am.
That's my biggest concern, the children in the neighborhood.
Thank you.
It's not a normal way of life.
Thank you. And I appreciate, I just want to just underscore and highlight and thank you for you all in Morrow Park for coming here today. You all are in District 10. And so I get those emails, I get those interactions and conversations and discussions on a very regular basis. But I want to thank you all for coming all the way from South Baltimore, sharing your testimony so that we can have a collaborative conversation about what needs to be done and how we can make sure to provide public health opportunities for all. So,
Well, Ms. Porter,
Yes.
also, there's makeshift tents. I've
Yes.
been threatened if I walk down the street, and if you look at an addict incorrectly,
thank you.
they want to come back to us and say something.
Sure.
And that's not feeling safe.
Yeah, and so we can definitely talk offline about that as well. I know I talk very candidly and frequently with Angie about what we can do, and so my office can help with that a lot more as well, along with the Mayor's Office of Homeless Services.
But I mean, truthfully, shouldn't you feel safe in your own neighborhood? I mean, these are, a lot of the older people, of course, have died off.
Sure. No, I thank you for that. Thank you so much. We'll go to the next testimony.
Hi, everybody. Good morning. My name is Cola. I'm a community organizer at the Baltimore Harm Reduction Coalition and a leader of the Bridges Coalition for Overdose Prevention Centers in Baltimore. Overdose prevention sites are a person-centered solution to help decrease overdoses and helps to create access for those unable to access critical services. Overdose prevention centers address isolation and uplift community engagement and growth. Using drugs alone can be dangerous, and at an overdose prevention center, people can have support during an overdose. Overdose prevention centers are also resource hubs with services like showers, laundry, case management, nap rooms, etc. Overdose prevention centers' effect on the community is large, and affects syringe litter as well as public drug use goes down dramatically. Overdose prevention centers don't increase drug use. That's a myth or a crime. And by bringing people who use drugs inside into a safe, supportive space, that helps keep them alive. In addition, partnerships can be made with overdose prevention centers amongst church and community centers. Thank you so much for listening.
Thank you so much. All right, before we start the agency, okay, we have one more.
Is this on? Okay. Hi. Good morning. My name is August Page, and I'm a social worker and case manager at Spark in Pigtown, a harm reduction drop-in center. First, I just want to extend my thanks to Councilwoman Porter and to Mayor Scott and all the council people who've been such strong advocates for harm reduction policies here in the city. These policies have undoubtedly saved lives, the lives of our neighbors, our community members, and for that I'm extremely grateful. But it's not news to anyone here that there's more work to be done. Just in the last year, we have lost participants at Spark, neighbors and friends in my community in Charles North and Remington, and that's just like scratching the surface of the enormity of loss that undoubtedly felt by many of us here. But when I talk to people about overdose prevention, the conversation so often is led with how do we help people quit drugs? And to me, that is the wrong question, right? And one that is rooted in harmful, stigmatizing, abstinence-based recovery ideals. In my experience and the experiences of many of my colleagues at Spark, preventing overdose does not happen in a vacuum. It doesn't happen without expanded housing, supportive housing programs, without overdose prevention sites where people can go and stay safe and alive. Most importantly, safe and alive, and connect to life-saving resources that are often painfully impossible to access for a lot of people, especially those who are experiencing homelessness. A lot of our clientele at Spark experiences homelessness. We see that as a huge barrier to people who do sometimes want to, recover or seek help in whatever way that looks for them, and the barrier for that is so huge, right? The issue of overdose is ultimately a housing issue, a healthcare issue, a mental health issue, a queer and trans issue, an over-policing issue, a dehumanization and access issue. It is my hope that in expanding and facilitating access to programs such as supportive housing and overdose prevention sites and facilitating access to these programs, we can help people to have their basic needs met first and foremost, because that, to me, as a social worker, as a case manager, like that is what I see as the main thing that can help people to have their, to support people in living and thriving on their own terms without harmful requirements for abstinence or dehumanization. So yeah, thank you so much for your time, Councilwoman.
Thank you so much. Is there anyone else that would like to testify before we go into agency presentations? All right. Health Department, I will turn it over to you all.
Good morning. I think we're actually starting with the mayor's office. My name is Dr. Letitia Jarasa, and I'm the Deputy Mayor of Health and Human Services. Thank you, Chair, members of the committee, for this opportunity to discuss the city's response to the overdose and opioid crisis. As we're pulling up the slides, just to briefly go over the agenda, today we will be talking about some key terms, so some definitions to level set. We'll also provide an overview of the overdose crisis, as well as some historical background. We'll review the city's behavioral health ecosystem. We'll discuss some existing programs and services offered by our city agencies. We'll talk about the Mayor's Office of Overdose Response's work so far, as well as the city's Restitution Advisory Board. We'll talk at a high level about the needs assessment and what we've discovered so far, as well as some strategic plans and priorities that are forthcoming. Next slide. So starting off with just some key terms and definitions, I think it's important to start there as we level set. Behavioral health, just broadly speaking, is the connection between a person's behavior, their emotions, and their overall mental health and well-being. Can we go to the next slide? Thank you. So when we think about behavioral health, it's inclusive of mental health, substance use, and again, that emotional and psychological well-being. Specifically, mental health specifically affects how we think, feel, and act, and it determines how we might manage our stress levels and engage with others. When we think about substance use disorder, I do want to stress that just like diabetes and hypertension, it is a chronic disease where people do compulsively seek and use drugs despite knowing that there are harmful consequences. And over time, there are changes to our brain chemistry if we use substances that do make it hard to resist using drugs, again, despite knowing that there are harmful consequences. So in that light, we've heard a lot of individuals discuss harm reduction. Treatment has to be individualized. It has to be ongoing, and it has to be fit and adapted to that individual's needs. Next slide. So I think as many in this room know, Baltimore City has faced issues related to substance use for a very long time, beginning with the crack epidemic in the 1980s, followed by the overprescription of opioids in the 1990s, which triggered that first wave of the opioid crisis here in Baltimore City. As a result of some national policies that we saw in the mid-2000s that restricted overprescribing, we saw an increase in heroin use, which drove the second wave of the crisis around 2010. And by 2013, we begin to see the third wave of that crisis, really related to seeing much more fentanyl in the drug supply and other synthetic opioids. And now in this fourth wave, we are still seeing the widespread use of fentanyl mixed with other substances, as well as some non-opioid sedatives, specifically xylazine is one that's being seen often. Next slide. So again, as we see with many chronic diseases, there are inequities. We know that this epidemic has disproportionately impacted the Black community, but for about 20 years, we did see that the rate of fatal overdoses were the same between Black and whites. In 2018, a disparity did begin to emerge in those overdose rates. And in most recent years, we have begun to see Black residents having a higher fatal overdose rate compared to every other racial group in the city. Since 2020, we did see that rate of fatal overdoses increase in Black residents where it began to decrease in white residents. And in 2023, that rate was 1.6 times higher for Blacks compared to white here in Baltimore City. And the overdose mortality rate for Black male residents over the age of 60 was 4.6 times the rate of white counterparts in 2023. Next slide. So given these inequities and outcomes, and specifically knowing who is impacted, we must target our interventions based on those inequities. Similar to what we did with COVID, understanding who was at highest risk, we want to, and we've done that needs assessment to understand how do we get to those that have been most impacted, where we see the most disparities. Next slide. So moving on to just a broader discussion about the city's behavioral health ecosystem, as well as how it's supported, certainly by city agencies, but by other entities across the city and state. Next slide. So I'm going to mention at a high level 5 major entities that do support the city's behavioral health ecosystem. We have the newly established Mayor's Office of Overdose Response, which is really the coordinating body for the Mayor's Overdose Cabinet and chairs the Restitution Advisory Board. We also have city agencies, some that are represented here today, the Baltimore City Health Department that provides overdose prevention, harm reduction, and treatment services, as well as our fire department that supports population health for our residents experiencing overdoses. We have our Behavioral Health System Baltimore, which is the local behavioral health authority. It's a nonprofit organization funded in part by the state that manages and provides oversight to the public behavioral health system. And then we have our community providers. So this is inclusive of our clinics. This includes hospitals. This includes community-based organizations that also provide education and treatment. And lastly, and very importantly, we have the state, which sets many of the regulations around overdose prevention, or overdose clinics rather, or methadone-assisted treatment sites, and they're responsible for licensure, oversight, and funding. Next slide, please. So speaking a bit more on the state's role, the Behavioral Health Administration lives within the Maryland Department of Health. So there's the state BHA, and then there's the local BHA, which is BHSB. That body is responsible for developing this comprehensive system of behavioral health services that are administered across the state. So that's inclusive of prevention, inclusive of early intervention, treatment, and recovery. So that's the organization that does licensing and regulates our public behavioral health system and our clinics across the city and state. They do work with BHSB to oversee and manage those services, and many of those services are funded through Medicaid, which also is housed within the Maryland Department of Health. Next slide. So speaking a bit more about Medicaid and reimbursement, so the state uses an ASO, or an Administrative Services Organizations, to pay for those behavioral health services. Many of our behavioral health providers here in the city do take Medicaid reimbursement, and then we have 9 MCOs, or managed care organizations, that pay for behavioral health care through primary care offices. Maryland Medicaid does cover a wide range of services, and most recently, about a year ago, began to cover crisis services as well. Next slide. So as we look ahead, and I think this was also mentioned in some of our public testimony, obviously we're still assessing the current gaps and resources that exist. We're thinking about what we know with potential changes or the funding that's coming to change to Medicaid, and how we'll, as a city and other organizations, need to step up and support residents across the city experiencing substance use disorder. Later in the presentation, my colleagues will discuss the creation of a new division within the health department that is focused solely on behavioral health, again, to help us think about how do we expand our workforce pipeline, and how do we ensure that we continue and expand on harm reduction, and that services remain cohesive and comprehensive. Now I'll be turning it over to my colleague, Allie, to talk a bit more about behavioral health here in the city.
Thank you, Dr. D. Good morning. We can go to the next slide. Thank you, Councilperson Porter, members of the committee. My name is Allie Smith. I really appreciate the opportunity to speak today. I wanted to take a moment today to begin by acknowledging the lives that have been lost in recent weeks during encounters involving people in crisis. Each of these incidents is a powerful reminder of why this work matters and underscores its urgency. Behind the policies and systems, we're talking about real people. The work I'll share today is one part of Baltimore's broader effort to build a system that meets people where they are with the safety and dignity they deserve. And meeting people where they are means recognizing that crisis is not a one-size-fits-all, it's a personally defined experience. What matters is how the person is experiencing it and whether the system is ready to respond with care. And while there's still more to build and improve, Baltimore is leading the way nationally in some of this work. Other cities are looking to our example, and that's not just something to be proud of, it's something to protect. Over the last 5 years, I've co-chaired the Baltimore City Behavioral Health Collaborative and helped manage the city's progress under paragraph 97 of our federal consent decree. Today's hearing rightly focuses on overdose response, but I'm going to briefly zoom out to share a systems level view of how Baltimore is strengthening behavioral health infrastructure citywide. The behavioral health section of the decree focuses not just on BPD, but on how the city responds to behavioral health crises, particularly minimizing interactions with law enforcement when appropriate. This agreement serves as the North Star for how we're transforming the system. And when I say we, I mean a generous, inclusive version of that word. I mean city agencies like police, fire, health, and others. I mean our local behavioral health authority, the stakeholders who show up, the providers, advocates, people with lived experience, especially those working with the Behavioral Health Collaborative. None of this moves without we. The consent decree required Baltimore to assess gaps in our behavioral health system, recommend solutions, and assist with implementation of those. We began with a public behavioral health gap analysis in 2019 and followed that with a multi-year implementation plan. But this isn't just about compliance with that decree. The infrastructure we're building is being built to outlive that. This section of the decree requires the city to create a 911 diversion program so that certain behavioral health calls and police encounters can be handled by trained clinicians instead of law enforcement. Build and sustain mobile crisis teams with enough well-trained staff, including peers with lived experience, to respond to people in crisis. strengthen peer support by helping secure funding, including Medicaid, to make peer roles more effective and sustainable, improve access to housing and homeless services so people with behavioral health needs have more stability and are less likely to end up in crisis, establish 24/7 comprehensive outreach teams that can connect people directly in the community whenever and wherever support is needed. And we certainly heard through public testimony today how much this is needed. And it requires us to create a permanent quality assurance process where agencies regularly review data, identify gaps, and improve how the system keeps people out of unnecessary police contact. We can go to the next slide, please. The Baltimore City Behavioral Health Collaborative convenes cross-sector partners to drive system-wide transformation. It plays a central role in the work needed to satisfy many requirements of this section of the decree. It's not just a task force and not just an advisory table, it's an active structure for accountability, coordination, and change. The collaborative has helped shape crisis response policies, review training curricula, push for more data transparency, and ensure that voices with lived experience are embedded in decision-making. It's co-led by the Mayor's Office, Baltimore Police Department, and Behavioral Health System Baltimore. The Fire Department also serves on the leadership team and co-chairs one of the committees. Members of the collaborative include people with lived experience, providers, advocates, and institutional leaders. And all meetings are open to the public, and people can opt to join in at any time. We can go to the next slide. I want to share a few key milestones, what we've actually built, and why it matters. We launched our 911 diversion 4 years ago with just 2 behavioral health call types. Today, we divert across 7 call types, including calls involving youth as young as 12 and second-party callers now. We've embedded behavioral health clinicians in the 911 call center so call takers get real-time support with triage and de-escalation. We're told that Baltimore is currently the only jurisdiction in the country with both 911 988 integration and embedded clinicians in our call center. We've also built out monthly quality assurance meetings and tracking tools so that the findings don't sit in reports or CAD, they drive real-time updates to training protocols and access. Our 988 helpline. Thanks to leadership from BHSB during the General Assembly, Maryland now has a permanent funding stream for 988, more than $25 million annually. Here in Baltimore, our 988 call center is not only scaling up, but leading nationally with the best answer rate in the country. And in February 2024, we saw about 3,500 calls into 988. By January 2025, that number rose to over 4,900 calls in a month. BHSB also launched one of the nation's first 988 community ambassador programs to build awareness and trust. This growth tells us 2 things. Public trust in 988 is rising, and we need to continue investing in outreach and education because we need to see more growth. That's why we've committed $10 million in opioid settlement funds to expanding awareness as 988 as a resource, and that 988 is beyond a suicide helpline. Crisis intervention training. About 23% of patrol officers have opted into Baltimore's 40-hour crisis intervention training, a course designed to better prepare them to respond when they are called to people in crisis. The collaborative has played a critical role in shaping this training. And this training isn't delivered in isolation. Community partners like NAMI and Baltimore Crisis Response co-facilitate key sections, bringing lived and clinical experience into the room. Each cohort also includes participants from across agencies like 911 call takers. So we're building not just individual skill, but cross-system alignment. Mobile crisis expansion. Over the last 5 years, BHSB has secured funding from multiple sources to grow our capacity. In just over a year, we've seen an 80% increase in daily mobile crisis team shifts. We also now have youth-specific teams. We operate across 3 providers, Baltimore Crisis Response, Inc., Affiliated Sante, and Grassroots. And sometimes they say we actually have 3.5 because there's another provider that has specialty teams. And every team includes both a licensed clinician and a certified peer. No police are embedded in these teams, and they're now reimbursable through Medicaid, helping us build a sustainable model. We've also incorporated virtual clinical support to expand our reach without overextending the workforce. Open Access Project. Moments of readiness for help don't follow a waiting list.
We heard that from Bakari clearly today. Led by Just Be, the open access project ensures that behavioral health providers can offer same day or next day appointments so people get care when they need it, not when a slot opens up weeks later. This matters deeply for people who use drugs, who may have narrow windows of motivation or trust. It's a small systems change with big human impact. Sentinel event reviews. These are one of our most powerful tools we have. They're structured, confidential, multi-agency case studies that allow us to ask hard, necessary questions after a behavioral health crisis or tragedy. What happened? What should have happened? And most importantly, what can we do differently next time? We've completed 8 quarterly reviews so far, each one involving city agencies, behavioral health experts, providers, hospitals. The goal isn't to point fingers, it's to identify the system gaps and missed connections that we can fix. Each review produces a set of recommendations that are shared transparently at our next collaborative meeting. They're tracked for implementation and integrated into our quality assurance structure. This is how culture changes, how we move from reaction to prevention, from blame to shared accountability. Housing and comprehensive outreach. Since 2022, our Mayor's Office of Homeless Services has placed over 400 individuals with diagnosed mental health conditions and over 270 with substance use disorders into permanent supportive housing in Baltimore. And in this fiscal year, we'll launch Baltimore's first ever 24/7 comprehensive outreach team thanks to a $15 million investment from our opioid settlement funds. This is the kind of infrastructure that helps people before they fall through the cracks, overdose prevention at the root. None of this happens in a vacuum. Over the past few years, I've had the privilege of witnessing that collaboration up close. It's not easy work, but it's deeply human work, and every step forward we've taken has been because people choose to show up, stay at the table, and build trust. That kind of partnership isn't just important, it's what makes the transformation possible. Next slide. Even with everything we built, the system is still growing and there are still cracks. There's still more work to do. Sustaining it will take more than money. It takes alignment, relationships, and commitment at every level of the system. Here are a few of our top priorities right now in that work. As I mentioned, we're preparing to launch Baltimore's first ever around-the-clock comprehensive outreach teams. Our 911 diversion, we're continuing to improve it. This includes evaluating where the program can responsibly grow next. Our embedded clinicians at the call center, these clinicians play a critical role, and sustaining this role is key. Real-time system improvement through our Sentinel event reviews and other quality assurance reviews. We're using what we learned to make real system changes, addressing access gaps, and strengthening coordination across agencies. 988 education and outreach. We've seen strong progress, but too many people still don't know when or how to use 988, and frankly, some still don't trust it. Continued outreach that's culturally competent is essential to building trust in this system. Mobile crisis response, we're focused on ensuring that when a mobile crisis response is needed, it's available. And that face-to-face response can happen within an hour, which is the national standard, and we need to continue to drive toward improved response times. EMS Peer Project. We're preparing to launch the EMS Peer Project, a new pilot that pairs individuals with lived experience alongside EMS teams responding to substance use calls. The goal is to provide support after the immediate medical response to help connect people to care and receive a warm handoff to community-based programs and stay engaged after EMS leaves the scene. The first team has been hired and a soft launch is planned for August, and will begin with 1 team and expand into 2. The future of this work really depends on how we choose to invest in it, tangibly and relationally. And my final slide. This is public work meant to be shaped by residents, advocates, providers, and system leaders alike. I want to acknowledge the complexity and nuance of what's being built. When we talk about systems change, we're not talking about abstract structures, we're talking about systems that serve real people. People in crisis, navigating trauma, trying to meet their needs in a city still healing from generations of inequity. And there's no single solution to that, not a single agency or individual that can do it. And that's why collaboration is a requirement of this work and something we have to continue to choose. It would be a missed opportunity if I closed today without some sort of call to action. Like council members continue to uplift this work and continue to advocate for the infrastructure and investment it requires and help us deepen the trust and relationships that make real progress possible. And for anyone, there's several ways to get involved with the collaborative. You can sign up for the mailing list. You can attend the quarterly meetings. The next one is July 22nd at 5:30 p.m. You can join a subcommittee. Just to give you a glimpse of what subcommittee work looks like, and the Policy and Advocacy Subcommittee, members will soon be reviewing a full spectrum of our quality assurance work and offering feedback on gaps and priorities that will directly inform the city's behavioral health audits. In the Data Informed Outcomes Subcommittee, later this summer, members will be reviewing the public-facing 911 diversion dashboard and informing updates to that. That kind of feedback loop is essential to keeping the work accountable. We also publish consent decree behavioral health progress reports twice a year. These are shared publicly and open for feedback, and we want to have that feedback. At the end of the day, what we're building is a system rooted in care, not crisis, and we need everyone, residents, providers, and public servants, to keep building it with us. Thank you. Yes, next person.
We can move to the next slide. Thank you. Good morning, everyone. My name's Jennifer Martin. I'm Deputy Commissioner for Population Health and Disease Prevention at the City Health Department. We're going to share a little bit about some of the programs and interventions in the health department, as well as we're joined by our colleagues from the fire department to talk about some of their work as well. Next slide. I'm going to start by showing this is the current org chart for the health department, and I want to just draw people's attention to the purple square in the middle of the page. Currently, this is my division, the Division of Population Health and Disease Prevention. Currently, we have overdose interventions and harm reduction activities spread across multiple portions of the Division of Population Health and Disease Prevention. We're currently in the process of doing some restructuring in the health department, where we will be creating a new division, a division of public behavioral health, where all of the current activities, as well as some new activities that we are planning towards with some of our restitution funding that has been allocated to us. So if we go to the next slide, apologies. There was supposed to be another slide in here showing the new org chart, but if you just go back. So we're going to be moving, again, the programs from the 3 boxes on the current org chart into a new division. And we will also be increasing some of our activities to support the work outlined in the mayor's executive order around restitution funding. I will pass it off to my colleague, Sherika Green, to talk about some of our health department programs. So next slide.
Thank you, Jennifer Martin. Good morning, community members. I'm Sherika Green, the Interim Director of Overdose Prevention, and I will now share with you the work we do in BCHD's Office of Overdose Prevention. First up, we have the Levels of Care program. It is a framework and certification for Baltimore City-based hospitals based on their ability to offer evidence-based components of care for patients with high-risk opioid use and opioid use disorder. Hospitals are rated on a scale of 1 to 3. A hospital that provides the full range of services, including capacity to initiate all 3 medicated assisted treatments for OUD, offer peer recovery support services, and dispense naloxone to ED patients and admitted patients at risk of an overdose. They're rated as a level 1. Level 3 hospitals provide more minimal services. Levels of Care has been operational since 2018. All hospitals in Baltimore City currently participate in the program. Next up, we have the Overdose Fatality Review. The Overdose Fatality Review team is made up of a diverse group of stakeholders who meet regularly to review cases of overdose deaths with the goal of better understanding why people in Baltimore City overdose and how we can prevent future overdoses. The OFR committee makes recommendations for interventions or policy changes, which are then shared with the OPT. Next is the Overdose Prevention Team, formerly known as the Opioid Intervention Team. It's a multi-stakeholder group that weighs in on Maryland Office of Overdose Response Block Grant funding and reviews recommendations for the OFR. Next slide, please. We have the Kids Off Drugs program, which is a culturally tailored school-based initiative that helps youth and young adults avoid or reduce substance use. This program is a collaboration between BCHD, BHSB, as well as Baltimore City Schools. The program was implemented in 2022. We have offered this program to over 800 students, middle school, high school, as well as college students. We have reached an additional 120 kids and adults through the KLD community events that we host once a year. The next initiative is a new initiative that Baltimore City Health Department rolled out. It's the Secure Sharps Disposal Drop Boxes. These drop boxes provide a safe way for people to dispose of syringes. We have been working with the community to place these drop boxes in strategic locations. We currently have 9 boxes installed. We started rolling these out back in July of 2024. So far, with just the first 3 boxes that we installed, we were able to collect over 450 pounds of syringes. The first 3 were placed in the Hamden community, Broadway East, and Milton Montfort community. We've gotten a lot of interest from community members who would like a drop box in their neighborhood, so we plan to roll out an application form that will allow communities to request these drop boxes in their neighborhoods. And then last but not least, we have another new initiative, which is our harm reduction vending machine. This machine is being piloted at Charm City Care Connection in East Baltimore. The machine provides low barrier access to harm reduction supplies, including naloxone, hygiene kits, safe for sex kits, safe injection kits, wound care kits, as well as pregnancy tests. Since implementation in September of 2024, the machine has already dispensed over 5,500 kits. The top 2 items that are accessed through the machine have been the hygiene kits and the wound care kits, followed by safe injection kits. And I will now pass it to Dr. Christine Oboy. Thank you.
Thanks, Sherika, and greetings, Chair Porter and members of the committee. I'm Dr. Christine Oboy. I'm the Assistant Commissioner for the Bureau of Ryan White and Community Risk Reduction Services, and I will walk us through the overdose response programs that are housed in this bureau. Next slide. Okay, the first is our syringe services program. This program provides mobile syringe services at 12 unique sites across the city. Monday through Saturday, our earliest shifts start at 9 a.m. and our latest shifts end at 11 p.m. And we'll talk more about our SSP program in the next slide. Next is our Staying Alive program. Our Staying Alive program provides in-person overdose prevention training to community groups by request and developed a virtual training for Baltimore City employees via Workday. In 2023 and 2024, over 13,000 naloxone kits were distributed and more than 11,000 individuals were trained on how to use naloxone through our Staying Alive program. The next program is our Syringe Services Oversight Committee, which was legislatively mandated by the state when our SSP was established. This committee meets quarterly and guides the Syringe Services Program team on programmatic changes, and also is a good vehicle to facilitate collaboration among state and local harm reduction providers and stakeholders. Next slide, please. Now let's revisit the SSP program. You will see we have an old photo on this slide from 1994. This is one of our original vehicles for our Syringe Services program. Our program was the first one in the state. It started as a pilot program after Baltimore City advocated for state legislation to allow us to operate an SSP. our syringe services program does a very important job of collecting used syringes and distributing sterile ones. With this intervention, the rates of HIV infection among people who injected drugs plummeted. When the pilot launched in 1994, people who inject drugs accounted for 64% of new HIV cases. And in 2017, they accounted for less than 6% of new cases. Since 2017, their transmission rate has stayed right around, but below 10%. In addition to syringe collection and distribution, the syringe services team provides peer support, referrals to treatment, overdose prevention education, STI screenings, and more. We take great pride in the work of our SSP team. Between January 2014 and June 2024, there have been over 170,000 client visits, over 550 drug treatment referrals, over 13 million syringes distributed, and over 8 million syringes returned or collected. We also provide syringe services using a backpacking model, where we go on foot to meet clients where they are. We also use this model to accommodate communities that prefer to not have our van present during an entire shift. Next slide, please. And of course, we don't do this work alone. Baltimore City has 8 other SSPs. Since SSPs became legal statewide in 2016, several community-based organizations, some of which you've heard from today, and the University of Maryland have open SSPs. We are grateful to partner. With these organizations that work alongside us. Next slide, please. And so we're moving on to another bureau within the health department. The Healthcare on the Spot Mobile Clinic is housed in the Clinical Services and HIV Prevention Bureau. This program has a partnership with Johns Hopkins School of Medicine, and it provides low threshold treatment for substance use disorder. The Spot Van services include wound care, case management, and access to buprenorphine, a medication used to treat opioid use disorder. Last quarter, the Spot Van provided 79 people with naloxone training and provided 400 people with low barrier access to buprenorphine. This concludes a portion of our presentation that summarizes BCHD's existing overdose response programs. Now I'll pass the baton to Chief Metz, who will discuss overdose response work of the City Fire Department.
Good morning, Madam Chair, members of the City Council, ladies and gentlemen. For the record, my name is James Metz. I'm the Assistant Chief of EMS and 911 in the Fire Department. Next slide, please. I just want to give some quick background on population health. I'm going to take a step back and just, the primary mission of the EMS and the Fire Department is to respond to both emergent and non-emergent incidences, some of which would be substance use disorder or people suffering from overdose. One of the things that we identified a few years ago was the need to be able to outreach the community in the community. We were lucky enough in July of 2023 to receive funding through the Ambulance Supplemental Payment Program to be able to establish a population health unit. Some of the goals of the population health unit were to expand the role of pre-hospital providers to assist units at the scene of 911 responses with mitigation or reduction of unnecessary transports to the emergency room, decrease 911 utilization, promote transport to alternative destinations and alternative means. That means to take people to the right resource at the right location. And this is important about the population health unit, is to provide point of care, remote link to resources and treatment, and we provide a mobile unit to bring resources to the patient instead of bringing the patient to the ED. The previous slide with Spot Van, it's been a great partner of population health. They've been a great advocate and partner of ours during that. When we actually started the program, there's 3 areas that we targeted that we thought were the lowest hanging fruit and the easiest areas to target. They were incidents involving suspected opioid and substance use disorder, high utilizers, and public health awareness. What's really obvious from the numbers is the amount of people that we've actually been able to outreach over the course of the last year and a half or so we've been doing the program. We've actually had direct contact with almost 600 patients, and then over 16,000 bystanders, family members, and community members. What are we doing with that? We're able to outreach those people, do things like Leave Behind Narcan, and do some outreach and awareness training. Post-overdose outreach, we've attempted to contact 217 people, but we've been able to actually successfully outreach 35 people and get them into treatment. Next slide, please. Some of the things that the state mandates that we do, we can't just leave behind Narcan or leave behind kits, naloxone. We actually have to do training events. We've actually been able to successfully do over 2,300 population health awareness events that actually targeted or came to be over 400 hours of community-based training. We left behind over 1,200 fentanyl strips, an additional 1,200 xylazine strips. Referrals to outside agencies are up over 836. Total resources distributed, food, water, clean needles, as well as wound kits. We're actually, the latest numbers, these are a little bit late, we're actually just about 11,000 incidents of doing that. And then long treatment center referrals were at 21. And then next slide, please. What does that mean? Well, we've been able to actually, these numbers are a little bit low. We've actually left behind roughly 16,000 leave behind naloxone kits or 32,000 doses of naloxone. What does that mean to the fire department? That means we've been able to realize roughly a 28 to 30% reduction in incidents of calls for opiate and substance use disorder and overdoses. That doesn't mean those overdoses aren't occurring. It just means they're not calling us out for that. The other thing that's a real advantage of the population health team is they're able to establish relationships with people in the field. What does that do? When those people are ready to seek treatment, they have a friend and we're able to link them and do a soft handoff. That's it for my slides, and I'm sorry, I don't know who follows me in these slides.
Thank you, Chief Matz, and thank you, Madam Chair and the esteemed members of the council. I'm Sarah Whaley, the director of the Baltimore City Mayor's Office of Overdose Response, and I'm so thrilled to have the opportunity to participate in today's hearing alongside my colleagues, the new deputy mayor, colleagues at the health department, and members of the fire department, and the many other agencies and offices who are engaged in this work and present today. The BC Moore office was created as part of the mayor's executive order that outlined how the city will guide the use of opioid restitution funds and assist in coordinating the city's response to the overdose crisis. BC Moore is a small but mighty team right now, and I just want to quickly shout out Augusta Gribitz and Miles Lichtman, our program managers, for their efforts to date in helping us build out our office. But I also want to echo what has been said by colleagues already today about the collective efforts of the folks in this room, the partners at other agencies, the individuals who are impacted by this crisis, and all of those who engage in this work, but also the residents who with compassion and understanding are looking out for one another, including those in crisis, and as we work together to address the overdose crisis in Baltimore. The work that has been done to date is building on existing efforts, and we're working to create something truly unique here, building on lessons learned and best practices from across the nation to create something that's specific and special for the city and for the people of Baltimore. We'll be presenting in depth on the opioid settlements and the opioid restitution funds at the hearing next week. So today I'm just going to focus on how our work fits into the context of the city's collective and collaborative efforts to address the overdose crisis. Next slide. So the executive order that was signed last August outlined the spending of the opioid restitution funds and how they should be strategic and aligned with the needs of the city. There are some key components of that executive order, including the creation of the BC Moore office, and also documents that the city should publish, including plans for community engagement, transparency, a needs assessment and strategic plan, and also how the city will engage with community members, bringing them together to advise on the opioid restitution fund through the Opioid Restitution Board. Next slide. Going to dig in a little bit on the Restitution Advisory Board. Applications for this board opened last fall after the signing of the executive order. The city received more than 180 applications. Candidates were scored and interviewed and selected by the mayor and then sworn in February of this year. The board is comprised of 19 members, including 13 members of the community who have personal and professional connections to the overdose crisis. To date, there have been 6 meetings. We've developed the board's mission and vision, are incorporating public feedback on the transparency and accountability plan and the plan for public community engagement, and preparing for the release of a request for proposal for $2 million in grant funding for community-based organizations. Next slide. As I previously mentioned, a component of the executive order was to conduct a needs assessment that will inform the city's overdose response strategic plan. These documents were released last Wednesday, and I'm going to pass it off to the Baltimore City Health Department to dig into the finding of the needs assessment. So Dr. Sadia McKeith.
Good morning, Madam Chair, council members, and everyone in attendance. I am Dr. Sadia McKeith. I serve as the Chief Health Policy and Strategy Officer at the Baltimore City Health Department. I'll be speaking towards the needs assessment at a high level. Next slide, please. Great. As mentioned, the mayor's executive order required the development of a needs assessment in order to inform the strategic plan. The needs assessment will occur every 2 years and is organized under 5 pillars. We had 3 aims to examine, and we tried to specifically look at residents' experiences with substance use and overdose crisis in the city, the recommendations people who live and work in the city have to address the overdose crisis in an equitable way, and how to best continue engagement around substance use and the opioid overdose crisis in a way that is fair, transparent, and well-managed. We conducted the needs assessment in collaboration with BHSB, so Behavioral Health Systems Baltimore, and BC Moore. And the needs assessment used both quantitative and qualitative sources. Quantitative data, for example, the numbers, the statistics, were collected from more than 15 different public and private data sources. Baltimore City Health Department's epidemiologists use a variety of ways to analyze that data and create different visualizations. Importantly, I want to let you know that we considered privacy and accessibility when creating data visualizations. We want to make sure people can understand the data, and we also want to protect the privacy of individuals who are represented in this data. For the qualitative data, so the stories that are informing that quantitative data, we gathered firsthand accounts from 71 community members with lived and living experience around substance use, 39 clinical and community providers, 16 city agency representatives from 14 agencies in focus groups and interviews, and we also received 217 responses to an online form from interested members of the Baltimore community. To analyze this information, we used the 5 pillars that you see on the screen. These are outlined in the executive order, and these 5 pillars serve as the approved uses of the opioid restitution fund. They are the social determinants of health, so in reference to the quality of life, the community conditions that make people healthy, helping people thrive, helping communities thrive. Prevention, helping people avoid drug use before it starts or before it becomes a substance use disorder. Harm reduction, keeping people safe if they are still using drugs. Treatment, helping people who want to stop using drugs. Recovery, supporting people to stay healthy and in recovery. Next slide, please. We had 3 different outputs. The first was the key takeaways. We had 15 key takeaways across those 5 pillars that I mentioned earlier. We had 5 recommendations based on those 15 key takeaways and 2 products. There is a published report, which you heard about earlier, and then a dashboard that's available online and public. Next slide, please. While the 15 takeaways are in the appendix, the key recommendations to inform that strategic plan are presented to you here. First is to address the worsening inequities in the city's overdose crisis. Second, to dismantle silos and improve connections throughout the systems of care. Third, to confront the systems of stigma and reduce the barriers to care. Fourth, increase access to low-barrier services for substance use disorders across neighborhoods, and number 5, improve the quality of substance use services across the city. Now, I will hand it back over to Director Whaley to speak to the strategic plan.
Thank you, Dr. McKeith. So again, as part of the mayor's executive order, and to align with national best practices, the city will use the finding of the citywide needs assessment to frame the overdose response strategic plan, which is the city's strategic roadmap that will guide how we collectively as a city work together to address the overdose crisis in Baltimore. Next slide. Through this plan and its priorities, the administration has set the goal of reducing overdose deaths by 40% by 2040. To accomplish this goal, we built a plan based on the recommendations of the needs assessment and lifting up those as our main priorities for funding and action. These priorities include addressing the disparities in the city's overdose crisis, dismantling the silos and improving connections throughout the system of care, confronting the systems, policies, and practices that perpetuate stigma to reduce barriers to care, increasing access to low-barrier services for substance use disorder across all neighborhoods, and improving the quality of substance use disorder treatment and recovery services. Next slide. Next slide. Along with each priority, there are a series of strategies and activities that we will employ. Some examples of those activities are listed here on the screen, and many of them are aligned with the requests or needs mentioned in public testimony. They include increasing the availability and accessibility of evidence-based services like harm reduction and treatment services in areas disproportionately impacted by substance use and overdose, and where existing services are not available or are not meeting the needs of the area. We aim to support ongoing efforts to utilize and grow our mobile crisis teams. As Ali mentioned earlier in the presentation, the need for behavioral health and substance use disorder crisis services remains a focus of work. The third one is to create access to support and connection of 24/7 specialized outreach teams. The fourth one on your screen is to ensure that our shelters are accessible to unhoused individuals who also have substance use disorder or use substances. We also aim to invest in initiatives that will increase same-day access to treatment services and are investing in 24/7 access to medication treatment. I want to note that this plan is a draft and a living document. This is not a crisis that we can solve alone. At the BC Moore office or the health department or fire, we have to do all of this work together. Next slide. And so, we have a plan for community engagement and public comment. The draft of the plan is open for public comment until the end of August. There is an online form that individuals in the community can visit and fill out. We are also hosting 4 listening sessions every week in July so that we can hear directly from residents about what their thoughts are on the plan. Our first meeting is tonight in Cherry Hill. Councilwoman Porter will be kicking us off. We're asking for other members of the council and their assistance in spreading the word to their constituents. Next slide. You can find links at these QR codes to the findings of the needs assessment, the strategic plan, and the public comment form. Thank you.
Thank you so much. Does that conclude the presentation? All right. So, I'm sorry? That's it. Yes, that's it. So first, I want to just acknowledge, just want to say thank you to you all for presenting today. I think that being a public health scientist with over 15 years experience, I understand the constraints of the local health department. I understand the opportunities of where we go from here, but also I understand that there's going to have some aspect of political will that comes from this very robust visionary plan. That kind of launches me into my first question. When we are talking about the vision of Baltimore, what I don't see is matching the realities of what's happening in our neighborhoods, the inconsistency with agency coordination,
and matching it to this vision. Can you all walk me through the process of, say, for example, Hamden, the existing realities of Hamden, the existing realities of persons experiencing substance abuse, community-based organizations, but also residents that have to kind of go through their neighborhood being revitalized to this vision. I have not seen that yet existed in any presentation. Can you all just walk me through that process of what that looks like?
Maybe I'll start and then kick it over to other folks on the team. And so I might ask for a little bit of clarification. So when you say the vision, is it how individuals access services, how the city provides support, how we support those with substance use disorder, or how we support the community? Could you clarify?
Yeah, so it's all of that, Dr. D. When we as council look at laws to be developed, we are looking at the realities of what's happening in our districts and our communities, but also we understand that there is a vision in play here. So we're talking about, for example, this particular plan is upwards of 15 years. That's a long time. And when we are looking at residents that have existed within these communities for a very long period of time, your presentation talked about from the 1980s. That's a long time. Walk me through the process of how we are to enact within community, how we're to actualize this plan from the realities that community-based organizations are going through, residents are going through, persons experiencing substance abuse, what they are going through, to the vision that you just presented to me.
Sure. No, thank you for that question. I think I'd first start by saying, and I think many of my colleagues talked about the need for enhanced collaboration and reduction of working in silos. And so I think we've probably all seen, anyone that's worked in public service, that there are many organizations doing great work, but perhaps they're not coordinated, or they're working in silos, or they're not aligned. So I certainly appreciate the establishment of an office like BC Moore, whose focus is a lot around kind of coordination. So how is the health department working with our CBOs? How are all the organizations working with the Restitution Advisory Board? So I think at the very least, it certainly starts with that vision of how do we better collaborate, how do we better align, how do we better communicate. I also want to underscore the importance of data. And so we heard a lot of people's testimonies. I think we have a lot of data. The health department has a lot of data on who's most impacted. And I think just like with the COVID pandemic or any health inequity that we're facing, we want to be both data-driven and community-informed. So I think certainly starting there, and then working with our partners at BC Moore, the health department, our CBOs, to provide a more comprehensive plan where everyone is discussing things together and has the same information. Maybe with that, I'll pass it over either to Director Whaley or Deputy Commissioner Martin.
I'll just echo what Dr. D said. I really think priority 2 in the strategic plan gets at many of the things that were mentioned, including the dismantling of silos. I think what I'm really interested in digging into more and what was identified in the needs assessment is really those silos in coordination of care. And so we can see where everyone is working within this ecosystem of providers, of agencies. We can maximize how we're spending funds if we know who is doing what, when, and where, and really drill down where those gaps are in the services that we're providing. I think the other component of that is the data infrastructure. So making sure that we have a robust data infrastructure that's used not just internally, but that also we can communicate that with the community partners on the ground, so that we can direct services where they are most needed. Again, maximizing how we're investing in this and the impact of our investments.
Good morning. I would also just echo what the Deputy Mayor and Director Whaley said, but also want to just highlight that there is a lot to be done. There is a lot of opportunity. And it's going to take sustained effort across the system, and really with the inputs and
participation of our communities. I was very moved this morning by the public testimony. And I think our listening sessions that we're holding this month are really, we really want to hear from community. So I hope that some of the individuals from Morrill Park who are here today will also participate in our listening session. If not this evening, then one of the other ones. We need to be community informed, as Dr. D said. And it is going to take a lot of sustained political will, as you said, and focus to achieve what we've outlined. But we have an incredible opportunity with the funds that the city has been able to recover, as well as with the coalition building that is underway here. And we know from what we were able to achieve during the COVID pandemic that when we work together, we can do amazing things. So I just want to impress upon our individuals from the public who testified this morning, it's so helpful to hear directly from you. We want to hear directly from you on an ongoing basis, so please don't hesitate to be reaching out to us. Please come to meetings that are being scheduled. If those meetings aren't working for you, let us know that so we can adjust. We want that input. The other thing I want to just mention is I'm very excited about the new division that we're standing up in the health department. We've been doing a lot of work for many years, as you heard about, but even though it's housed in one division, it's in different parts of that division. And I think moving into our new structure is really going to give us an opportunity to be more efficient and effective and collaborative and directive with the activities of the health department. And so I just wanted to share that as well in terms of thinking about how we are building the will and the focus within the health department and building our infrastructure to be focused on these areas of behavioral health. So thanks.
No, I appreciate that. And I just also, I thank you for those responses. What I think we have to get past is the exhaustion that's happening in community. The exhaustion that's happening from the numerous plans, the exhaustion that's happening with going to the state level year after year, the exhaustion of making sure that there is an interagency approach. So help me understand a timeline. I know, Sarah, I saw the spreadsheet. You're doing a great job in that respect. However, there has to be an additional sense of urgency with that interagency collaboration. And we have to come to some sort of connection, interagency coordination yesterday. And so do you all have a timeline with where in which we are finally getting that interagency collaboration together as it relates to behavioral health and substance use in our communities that we're seeing?
I can speak to that a little bit. I think a lot of that is happening already with the new overdose cabinet, the overdose working group. The agencies that are in this room have come together, and I think this plan is an example of action that we have taken over the last 6 months, but even longer, of agencies coming together to really think strategically about how we're addressing this, to put that on paper. Again, to your sense of urgency, we also have the $87 million in earmarked funding from the restitution fund that we are working diligently to get grant agreements signed, and I'll just uplift the Mayor's Office of Recovery Programs for their work in that, to get money on the ground and making sure that the scopes of work for all of those programs are aligned with this strategy. So it's not, the agencies are working together. We have Overdose Stat as well, where we are checking in regularly on the data and how we are working. The Overdose Cabinet meets monthly, again, coordinating our action and the products that we produce. And then just the work of our community partners as well, building those coalitions. We have a meeting on next Friday with community partners. We're calling them Lincoln Learns. They're coming out of the BC Moore office. So I think A lot of that is happening now. I will stress that this plan is a 2-year plan, so our long-term goals are 15 years in alignment with the scope of the restitution fund, but this plan is 2 years. And so we will be checking in regularly, adapting the plan as needed, conferring with the data to make sure that our efforts are having the outcomes that we are aiming for, and adjust when necessary. And so I think that's, yeah.
Thank you so much, Executive Director. Ty-Lor, can I make a formal committee request, please? If we can have, you mentioned like the past 6 months of like overdose stat. One of the missing connections is connections with the council's offices. If I can request a quarterly or every 6 months where we are connecting with each of the council members about the data that's shared within overdose, overdose stat? Yeah, in the Behavioral Health Council. One of the reasons why I bring that up is because, Allie, to your point, those Sentinel reviews, there can be a connection not only with what you're seeing in the data, but those Sentinel reviews, but what council members are seeing on a daily basis. We get those emails literally every single day, probably multiple times a day, of things that are happening. We need to connect those dots and utilize the infrastructure of the council's offices along with the mayoral offices, along with community-based organizations as well. So we can kind of serve as that integral connecting part with you all as well. So I'm requesting that we have those briefings with each of the 14 council members every 6 months about the data that's being presented in overdose stat. Thank you. I'm going to turn it over to Councilman Parker.
Thank you, Madam Chair. Thank you to the public for being here. Thank you to our agencies and representatives for your engagement over many years in this work and your partnership with us today and in the years to come. A few things to check in on. So I want to start, data has been emphasized. I know the city and especially the health department have placed a lot of emphasis on collecting and sharing good data. The request from the chairperson for a review of that with council offices is deeply appreciated. I want to note, I think I have this correct from news reports, and probably we covered it in budget hearings too, that between 2023 and 2024, in addition to 27% drop in overdoses in the country, we saw a 34.8% decrease in the city of Baltimore in overdose deaths. Is that more or less correct, from down to 680 from more than 1,000?
That is correct, but I also want to caution that the data is still preliminary, so subject to change.
Very good. Given that, and that this top line goal by 2040 over 15 years is a decrease of 40%, conceivably we might be in the mid 30s. When are we starting, just to be practical, when are we starting to count from? 2023 numbers, what's the year we're counting from?
That's a great question. Sarah and I have talked about this many times over the last several weeks. The health department's recommendation is that we measure that from 2023 because the 2023 data is still also preliminary, but we have a pretty high level of confidence that that number is not going to change significantly.
And the reason I mentioned the national data is because there's lots of trends outside of the city of Baltimore. We know that Baltimore has its own particular history and reality of dealing with addiction and with overdose in particular. And yet there are national trends that we are not immune to. And so that 27% decrease is certainly part of the decrease that even with preliminary numbers we've seen here. And that there's going to be national trends up and down over these next 15 years that will shape our reality, even as we work really hard and bear down on the issue here. That being the case, though, is that percent goal too low, given the vagary? I mean, given what a dramatic decrease we saw in 1 year, even before many of these interventions come online, and wouldn't it still leave us with a pretty, because our rate was so high compared to peer cities, wouldn't a 40% decrease, although it's something that we absolutely want, leave us still relatively too high compared to cities like Philadelphia and other places that have also seen really high numbers, but still nowhere near our rates. And so I would just I would ask whether we ought to be more aggressive here, given how much we have coming online and how big an issue this is, if our goal ought to be, given the national dynamics, ought to be more than that, that our city and communities need a greater reduction than this.
I appreciate that question and comment. We have had a lot of discussion, as I mentioned, between Director Whaley's team and the Health Department's team around this. I think it's difficult for us to come up with a goal just because there is so much fluctuation in the data and we don't have full control over when those investigations will be completed. I completely hear you and agree that 40% may not be aggressive enough, but we feel like it is it is reasonable, and we could potentially, if it would be helpful, provide some explanation of how we arrived at that. We could prepare that for council, perhaps as part of the report.
I will also just add that looking at some of statistical projections, our goal is more aggressive than what some of the projections show. And I think taking into consideration the additional funding and our coordinated efforts now, we kind of adapted what was in those projections to make it a bigger goal, because we know the work that we're doing and we believe that that's a good goal for us to have.
I appreciate that. Thinking of particularly vulnerable communities and recognizing that addiction looks different, as the chairperson said, and as many of our public testifiers said, even neighborhood to neighborhood addiction functions and works differently, and certainly city to city. Thinking about particularly vulnerable populations, we know how big a role Medicaid and Medicaid access plays into accessing treatment and accessing existing programs that are here. We have certainly we have folks in our community who don't have access to Medicaid because of immigration status or other barriers. I know nationally there's been data that has shown not only vulnerability among older Black adults, which and older Black men, which we've focused on here in particular, and it has particular bearing on Baltimore, but also that younger Hispanic or Latino people are particularly vulnerable, in part because of, driven I think in part by lack of access to Medicaid and other resources. Do we have data in Baltimore? Are we tracking data in Baltimore specific to our Latino population by age demographic or not? And what is, if yes, what are we seeing there so far, and how does that fit into our strategic approach, especially around language access or recognizing barriers to insurance or other things that heighten immigration enforcement that keep some of our immigrant neighbors, creating even more barriers to them accessing the services that exist?
So we do look at that. If you look on our dashboard, you will see that breakdown. We are seeing low numbers of both fatal and non-fatal overdoses in individuals who are Hispanic. And so for some years, the data is actually suppressed because the numbers are so small. Yeah.
Right, understood. Thank you for that. My last question is this, Madam Chair, if it's okay. Okay, great, thank you. A lot of our community members and advocates and people who are engaged on a day-to-day basis spoke about safe consumption sites, safe consumption centers, things like that. I know it's been a subject of plenty of conversation at the state of Maryland level and here in the city of Baltimore. I'm new to those conversations as a council person, and so I don't want to presume that I have in-depth knowledge of the conversations you all have been a part of. But I do wonder, given our current resources and our renewed attention to what has always been a major priority here for the city of Baltimore, is there some sense within the strategic plan for a renewed effort or an approach that involves such centers or such sites?
Yes, within the strategic plan, you'll find reference to things like low barrier access to harm reduction services, which feasibly could be something like an overdose prevention center. So we're looking at various models that may work in Baltimore to increase access to low barrier types of services.
Thank you for that. Thank you, Madam Chair.
Thank you so much. Councilman Bullock?
Thank you, Madam Chair, and thank you everyone who's here today. I have a question that's a pretty broad question, but it's really around community partnership, but also the impact on communities. We heard some testimony earlier that really speaks to some of the challenges that we deal with in neighborhoods, but also opportunities. So on one hand, we know, for instance, that at the state level, the Maryland Department of Health regulates the service providers. At the same time, we know that in communities, there are also some entities that pop up. And that has also caused a lot of challenges in neighborhoods. One, just in terms of the lack of notice in some cases, and also, as was mentioned today, the overconcentration. So particularly we look at places like West and Southwest Baltimore, that yes, while there are challenges with folks who are suffering from substance use disorder, there's also an overconcentration historically. And so that you may have folks from other parts of the city accessing services within those neighborhoods. So that's one piece in terms of how the city and state work together with that, because we do hear it in our neighborhoods, as Councilmember Porter mentioned. And then on a positive side, we are fortunate in our district to have a stabilization center. And so one of the things that I'm curious about is the utilization of stabilization centers. Have we seen the numbers go up? Are they pretty flat? Are we also looking to expand those types of opportunities? Because as we've seen in our neighborhood, they have been actually a pretty good partner and actually doing some really good work. So if you could address those points, I'd be very grateful. Thank you.
So I do just want to acknowledge we have our colleagues here from BHSB who do provide oversight to the Crisis Stabilization Center. So if one of them could maybe come up and provide some response to that.
Good morning, Adrienne Bridenstine, Vice President of Policy and Communications at BHSB. I don't have the utilization numbers handy, but I can follow up with you, Councilman, on where we are with that. But you know, we launched the program several years ago, and we've been working very diligently, especially since COVID, right? We had to, like many programs, utilization went down during COVID, and we have been working very closely with Turk House and other providers to gradually see that increase, or to see utilization go up. And we have been seeing that. I just don't have the exact numbers in front of me, but I can definitely follow up with you.
And thank you for that. And just, you know, for the larger point, I think it's just really important in terms of diverting folks away from emergency rooms, but then also treating people within neighborhoods and giving that level of dignity as well. So again, I just wanted to make sure folks are aware of that as an entity. So I thank you for that.
Thank you for bringing
And Councilman, is that a formal committee request?
Yes, thank you. That'd be very helpful.
Thank you so much. Councilman Dorsey?
Thank you, Madam Chair. Thanks, everybody, for working on this. I tend to lay low on this subject, largely because I have a lot of firsthand personal experience as a recovered alcoholic, former drug user, sober for many years. I have very personalized perspectives on addiction, recovery, treatment. But one thing I can say that I've come to understand as absolutely critical to our path forward is overdose prevention centers. That I don't think that we can get this going quickly enough. That they are life-saving. That I know people who have attempted recovery successfully, unsuccessfully, and not attempted. And that even those who are successful often are not successful at first and can have, in some cases, many, many years of deeply dehumanizing life experiences between the time when they begin their foray into the possibility of recovery and when it becomes a reality for them. And among those who are unsuccessful, they could be unsuccessful and in attempts at recovery for many, many years and decades. And while I'm familiar with how the experience of living with closely or at a distance, as a family member, as a friend, as a community member, living with people who are living with addiction, experiencing addiction, and not yet ready for recovery or not yet interested in recovery. As painful as it is to watch, it's absolutely tragic when they die unnecessarily. And that is the difference that overdose prevention makes, is the possibility that people do not die unnecessarily. And because it's not just overdose prevention, that in my awareness and experience, it exists in a place of deeply communally rooted harm reduction. It offers those people who are just not dying also the ability to live a higher quality of life even while in addiction and use. And I mean, I'm so thankful for the partners that we have here in Baltimore leading in harm reduction. I want for us to not use soft pedaling language when we talk about this, that we as a city actually need to be just very clear. We need overdose prevention sites. We need overdose prevention centers. And we've been talking about it for long enough that I think, you know, it's concerning when I don't hear it right up front and really clearly not tiptoed around as naming the thing that we need. And I also know that these programs work when they are located in communities where the need exists, and that our partnership outside of government and people working directly in service to those who need it are attuned to where it is needed, and that's very localized. The need, when I asked On Point folks in New York about their locations, we wouldn't put this in that neighborhood or that neighborhood or that neighborhood because that's not where the need is.
And Councilman, 2 minutes.
Okay. And so I guess do we have and are we developing a clear understanding of where the need is most concentrated or proportional? I guess, do we have a strong system for understanding that, not just through government, but also through our partnerships? Do we feel as a city that we know proportionally where the need exists in the city?
Thank you, Councilman. I think we have a good understanding, but I also want to reiterate that we want to be data-driven and community-informed, and so we do want to make sure that we are hearing all voices in community to have the full picture. One thing that I can share is, in the health department, one of the things that we're doing as part of the development of the new division is to increase our data capacity and data team to be able to look at the existing data sources we have, but also to increase our capacity and develop additional data sources. And as part of that, we definitely want to be thinking more about collecting this qualitative data, this community input, which would be from both members, residents of the city, as well as our partners in the community-based organizations.
I totally respect qualitative data, but what about quantitative data?
Yes, we also are increasing our capacity around quantitative data as well. We've been working closely with both the Maryland Department of Health as well as Behavioral Health Systems Baltimore to be able to pull together additional data sources and to be able to look at those to be able to better paint a picture of where need is and what needs are in different parts of the city. So we are also increasing that capacity.
So if you had to right now, if we were to say our ability to map proportional need in the city is how good is our ability to do that? If I had to say on a scale of 1 to 10, our ability to map proportional need in this city, where are we on a scale of 1 to 10?
Well, as any good data scientist knows, I would want to make sure we clearly define what we mean by proportional need. I mean, I'm not trying to diminish what you're asking, but I think we do have to define things and have a clear understanding of what the problem is and what we're trying to address. That said, I think we do have we have good capacity to do that, but it comes down to what is the exact problem that we're trying to measure and quantify and think about in terms of the need across the city.
Madam Chair, if I may add.
Sure, and this will be the last comment before we go back.
Thank you. JD Merrill, Mayor Scott's Deputy Chief of Staff. I think the Deputy Commissioner has been a little bit too humble in answering that question. I want to be very clear. The Health Department has a tremendous team of epidemiologists, 2 of which are in the back here today. Every month at Overdose Stat, we're looking at the map of where fatal and non-fatal overdoses are happening in the city. We're talking about the resources and the support that are needed in those communities. We have outstanding data, we have outstanding tools, we've got an outstanding team in the health department, and the plan that the health department's developed with the $20 million for infrastructure is only gonna bolster and enhance that. But I wanna be clear, we already have that work underway.
Thank you.
Thank you so much. And just to follow up on that question, one of the, Councilman, I understand the logic behind your question. One of the major issues that we are dealing with, particularly in districts 7, 8, 9, and 10, is that we know that those are the areas of most need throughout the city. However,
I can't help but bring back my point of interagency coordination, because the plan is great. And Deputy Mayor Merrill, what you've described, we have that within the health department. What we're not seeing is the sustained execution of those types of services with community-based organizations in community for a long period of time, like the sustainability aspect of what we're seeing in community.
Thank you, Madam Chair, for bringing that up. And while we released the needs assessment last Wednesday, I want to be clear that to all of us in the room, the needs were apparent far before the needs assessment was released last Wednesday, right? And one of the first things that we heard and that we acted on was this desire for interagency coordination, and that's why we created the Office of Overdose Response in the Mayor's office and hired an executive director, because we know that this isn't going to be solved just by the health department or just by fire. We need all of our agencies, all of our community partners, all of our residents working together to solve this. And so, again, while the needs assessment came out last week, we saw that need for interagency coordination. We created the office. We created Overdose Cabinet, where we have cabinet members coming together every month, and we're already working on it. So while this hearing is happening today, I want to be really clear, this work has been ongoing, it's been sustained, it's been a top priority of Mayor Scott's.
Thank you so much, Deputy Mayor. I think that we're at a point in time here where this conversation is going to have to be ongoing. We've experienced a lot today. We held a lot today. We held a lot of space today. I know we have three additional legislative oversight hearings over the past, in the next month in July, but we're going to continue this conversation. I think that we have, an obligation to underscore the need of what so many people have been seeing for generations, but also we've got to keep going and really execute on that sustained interagency coordination. From my understanding, hearing what's in community and also hearing from advocates today and also hearing from our agencies, the continuous starts and stops of these types of initiatives can't happen anymore. We just can't afford it. We cannot afford any more lives being lost because of the misalignment of agency, the misalignment of values, the misalignment of political will, and also just the lack of understanding of what is really happening within our communities. This is an opportunity for us to, I'm glad you're having the listening sessions. This is an opportunity for us to go into community, but know that you are going to be met with community exhaustion. Know that folks, don't want to come to another meeting with no specified outcome. And so, again, you have our connection and our courage here within this committee under my leadership to continue to show up, but know that we have to get this right this time. We can't keep doing status quo and doing things as we normally have been doing in the city. And I just want to also thank Mayor Scott for having the political will to take this courage and this mantle up. This is not a sexy subject for people. This is oftentimes a really complex conversation that brings together a lot of different opinions, a lot of different ideas, but knowing that we have the full commitment of this council for human dignity, but for also resident outcome and resident experience as well, that's going to be very married in the conversations that we'll have moving forward within this committee. So I'm going to recess now because I'm looking at you all and you all look like you need to eat lunch. So I'm going to recess this hearing and I'll see you all next week.